Hello, and welcome to another emergency question and answers for families in ICU and intensive care at home. My name is Patrick Hutzel. I'm the host of this show. And before we go into today's questions, I want to quickly do some housekeeping. If you want to type your questions into the chat pad, please do so. Or if you want to talk to me directly, please use the StreamYard link that I'm just posting into the chat pad. Here it is. And then you can talk to me directly here. I welcome any questions that are related to intensive care at home, and if you have a family member in intensive care or in LTAC, depending on your location. We'll be going for about an hour where I answer your questions, and we've got so many emails coming in every week that there's no shortage of topics to talk about. In the meantime, what makes me qualified to answer questions for families in intensive care or intensive care at home? I'm a critical care nurse by background. I have worked in critical care nursing for 25 years in 3 different countries, where I worked as a nurse manager for over 5 years in critical care and intensive care. And I've been consulting and advocating for families in intensive care all around the world here at intensivecare.hotline.com. And I can very, very confidently say that we have saved many lives with our consulting and advocacy since 2013 here at intensivecare.hotline.com. And you can verify that by going to our testimonial section at intensivecare.hotline.com, and you can read our clients' testimonials there. Or you can go to intensivecare.hotline.com and you can watch our intensivecare.hotline.com podcast and look up firsthand what our clients say on the interviews. I'm also the founder and managing director of intensivecare.hotline.com I'm also the founder and managing director of intensivecare@home.com. With Intensive Care at Home, we are providing a genuine alternative to a long-term stay in intensive care, and we are sending our critical care nurses into the home 24/7 to provide a genuine alternative to a long-term stay in intensive care, predominantly for long-term ventilation and tracheostomy, but also for tracheostomy care without ventilation and for BiPAP, CPAP ventilation without a tracheostomy, right? So, and we're employing hundreds of years of critical care nursing experience combined in the community. We are currently operating all around Australia, in all major capital cities, as well as in all regional and rural areas. And we are NDIS approved, TAC and WorkSafe in Victoria, iCare in New South Wales, and IISQ in Queensland, as well as the DVA all around the country, the Department of Veteran Affairs. We have also received funding through public hospitals, private health funds, departments of health, and so have our clients. Okay, so I also want to welcome our viewers on replay, because I know there's quite a few people always watching this on replay. Now, let's look at the first question today. Today I want to start with an intensive care at home question. We had an email from a case manager who's asking whether in ICU, case manager in ICU, whether we can take the following patient home, right? So it gives you an idea of the capabilities of intensive care at home. So the patient has a tracheostomy in place with a ventilator. The patient is not in distress with the tracheostomy in place, attached to a ventilator, feels comfortable and has tolerating the weaning of pressure support mode of ventilation. The patient remains on pressure support most of the day, and respiratory secretions and mucus were suctioned to avoid mucus plugging. This happens quite frequently. The patient is also on regular medication such as Lasix twice a day to manage the patient's fluid balance. The patient has slightly distended hyperactive bowel sounds pitting, upper and lower extremity edema, and the patient's eyes are open, the patient is following commands and does track and have minimal spontaneous movement. The pathology results taken showed abnormal levels of white cell count, red blood cells, hemoglobin, hematocrit, platelets, blood urea, nitrogen, creatinine, and point of care glucose. The patient also has a low blood pressure of 104/70. That is not a low blood pressure, by the way. A low blood pressure would be anything that's less than 90 systolic. Close observation and monitoring of the patient is suggested, and administration of the prescribed medications, feedings, and treatments with additional water flushes is allowed to improve the patient's abnormal blood levels and prevent other complications such as dehydration, fluid overload, electrolyte imbalances, and others. To maintain a patent airway, clear secretions, maintain good oxygen saturations, proper positioning and mobilizations, and aggressive chest physiotherapy, including cough assist, lung exercises, breathing exercises, duo nebulizations or hypersaline nebulizations to avoid mucus plug, the airway, and promote ventilation, oxygenation, and tissue and organ perfusion. It's important to keep the patient comfortable and pain-free at all times, and always observe infection control practices and precautions for continuous decrease and elimination of infection in the patient's body system. Well, this sounds right up our alley. This is what we do with our clients at home. You know, we have similar clients at home in similar conditions. And what is noteworthy here is that, you know, the case manager is talking about infection control practices. Well, here's the reality. An ICU is full of infection, full of bugs, right? And it's quote unquote dirty. Now you go to someone's home, it's a much cleaner environment, and the infection risk is much lower. Once again, going home is a win-win situation. Now, let's look at the pathology results of the patient. Sodium is 138, which is normal. Potassium is 4.1, which is normal. Chloride is 99, normal. Blood urea, nitrogen is 36, so it's a little bit on the high side. Creatinine is 0.47, which is a little bit on the low side. Calcium is 8.7. White cell count is 10.7, which is just about normal. Red blood cells is 2.9, a little bit on the low side. Hemoglobin 8.4 on the low side. Hematocrit 25.5 on the low side. Platelets 467, which is high. Vital signs: temperature is 37.5. Heart rate is 100 beats per minute. Respiration rate is 28 beats per minute. Saturation is 93%. Blood pressure is 104/68. Once again, that is not low. That is on the lower side, but it's not low where you can't have kidney or other organ perfusion. Now, next. The main diagnosis for the patient is hypoxic respiratory failure. And there was a worsening respiratory status and obstructive pattern on the ventilation. The inner cannula was stuck with a mucus plug, which was replaced. The patient was started on low-dose Precedex given the agitation. Now, what is important to note here is that, you know, if an inner cannula had or was blocked because of patency issues, right, we have a big problem. And that could lead to the death of a client or a patient. And in a home care environment, that needs to be prevented. You know, our promise with intensive care at home is to keep our clients at home predictably. Our promise is to have no non-elective hospital readmissions. Now, if it's an elective readmission, a planned one, that's a different story, right? But what we are trying to achieve is no non-elective hospital readmissions, no hospital readmissions that are unplanned, and you know we're achieving that. But this is also where our skill comes in, right? Our skill is to take patients at home that otherwise would be stuck in ICU long term, right? So if anyone who's watching this is, working in an ICU and is wondering how is this going to work, well, it's working by having the right skills at home, having the right mindset at home, because it is often also a mindset issue, right? And it's a case of building the infrastructure that is needed to take our vulnerable clients at home and keep them at home predictably, right? And we do that by deploying a critical care nursing workforce in the community that knows what they're doing and that are the right fit for the clients. One of the biggest challenges that we are facing as a provider is simply finding the right staff for the right client. You might be watching this and you might have a family member in intensive care, or you might have a family member at home already, and you're thinking, well, how is this going to work? Are these people that are coming to my home, are they the right people? And that is a very valid point, right? Are the people that we're employing the right people? Well, first of all, I do believe that the people that we are employing are self-selecting, right? They read our job ad, or they hear through word of mouth, that, hey, you should come to intensive care at home. You're a critical care nurse. You can take your critical care nursing skills into a different environment. It's very interesting working with intensive care at home. It's very rewarding working with intensive care at home. And by that I mean not only rewarding in a monetary sense, it's also rewarding working with our clients and their families to improve their quality of life, or in some instances improve their quality of end of life, right? And it is, once again, it is all about a win-win situation. Now, this particular client, what I forgot to mention is also had, what got the client into this situation in ICU in the first place. Client had a stroke. Client had a CVA, cerebrovascular accident, right? So that's what got her in this situation in the first place, right? So, but I really hope that that helps you understand what we are capable of at home. What I should also mention is that we are providing all the equipment, right? Patient like this needs 2 ventilators at home, 2 suction machines. Patient needs heart rate and SATS monitor, needs a special care bed, a hospital bed, needs a hoist, a lifting machine, right? But also needs the right infrastructure at home, right? And that's what we're all about. It's all about creating the right infrastructure for someone at home who needs specialized care like this particular client needs, right? Okay, now if you have any questions, type them into the chat pad, or connect with me live here on StreamYard. Click on the StreamYard link that's in the chat pad, and then you can talk to me here directly. If you don't have any questions, you just want to listen in, then I will read out the next email that came in during the week. Hi, Patrick. My mother had emergency open heart surgery during a TAVR surgery and is now on the ventilator. That was on Tuesday. It's been 3 days since the surgery, so 4 days now, and she's still on the ventilator, but the doctor says she isn't ready to come off it. So that is a great question. It also ties in with one of the most frequently asked questions we're getting, which is, how long does it take to wake up for a patient after cardiac surgery, right? So let's just quickly clarify the terminology. TVA repair, actually should be TV repair, tricuspid valve repair, right? It's a valve in the heart, basically, and it's either a repair or a replacement. You haven't actually pointed out in your email whether it's a replacement or a repair, right? And there's a difference there. Repair is the cardiac surgeon will repair the valve, or the replacement means the heart valve will be replaced completely, either with the tissue valve or with a mechanical valve. Either way, when someone is having open heart surgery, it's high risk surgery, right? The chest is cracked open. Patients are on a bypass machine, right, for hours, sometimes, for many hours sometimes. The lungs are deflated during the open heart surgery, right? And while the lungs are deflated, to make room for the surgeon to operate on the heart, right, the patient is put on the bypass machine, which takes over the function of the heart and the lung for the time of the surgery. Now imagine someone's operating on your heart while the heart is also being stopped, right? The heart is also being stopped. And you're on a bypass machine where the bypass machine is doing all the work, for the heart and for the lungs in the meantime. There's an element of risk, of course, that can be controlled, right? There's an element of risk that is there, but it can be controlled. It's in a controlled environment as much as possible, right? But with the lungs being deflated, with someone operating on your heart, there's high risk for bleeding, for example. There's a high risk after surgery for irregular heart rhythms. With the lungs being deflated, there's a high risk for a pneumonia to develop, right? So those are some of the risks. There's also a high risk for patients going into cardiac arrest. There's high risk for patients skipping beats within the heart, and they might need a pacemaker, or at least some pacing leads in the short term that hooks them up to a pacemaker machine, even if it's only in the short term to get them through the first few days in ICU, right? There's also a risk of hemodynamic instability, which means blood pressure might fluctuate, heart rates might fluctuate, especially with, once again, someone's operating on your heart. They've got the heart in your hand and they do all sorts of things, right? I've seen it when I worked in ICU. I've seen cardiac surgery as a student in the operating room. So you can see that this is high-risk surgery. And whilst most patients in a situation like that, they are on a pathway. So what I mean by that is a pathway is set out for them. You follow actually a pathway in ICU. You say, 2 hours after surgery, you warm them up to 36 degrees, right? Every 15 minutes, you're checking observations. You're checking cardiac output. You're checking cardiac index. You're checking SVR. You're checking that there's no bleeding. You're checking the chest drains. You're checking blood results, chest x-rays being done. You're making sure that the blood pressure is titrated within a certain range. You're making sure that the heart rate is within a certain range. You're making sure the temperature is within a certain range, right? And then if all goes well, the patient should be off the ventilator within 24 hours, really. That is often what those pathways are suggesting. Now, life is unpredictable and things, can not go as planned, not as the pathway suggests. And that is probably what is the case in your situation here, where, things are not straightforward. There could be some bleeding, right? There could be a tamponade, which is internal bleeding that can compromise the heart and could lead to cardiac arrest, right? There could be some irregularities from the heart, right? Like your family member might have gone into AF, atrial fibrillation, right? Might have gone into VF, ventricular fibrillation, might have gone into VT, ventricular tachycardia. They might be skipping some heartbeats and they may need to be put on a pacemaker in the meantime, right? They may be in a lot of pain, right? Maybe they are hemodynamically unstable to the point where blood pressure is too low or too high. And if blood pressure is too low, Is it because they've lost too many fluids, a lot of bleeding during surgery? Do they need to have blood products such as red blood cells, platelets, FFPs, fresh frozen plasma, to name a few? Or do they need some albumin, right? If they're hemodynamically unstable and the blood pressure is low, do they need vasopressors or inotropes such as milrinone, dobutamine, epinephrine, norepinephrine, or adrenaline, noradrenaline, vasopressin? Do they need any of that? What is their ejection fraction? Right? Ejection fraction refers to the contractility of the heart and the pump function of the heart. So after cardiac surgery, a patient should have an ultrasound of the heart. What I've also seen on occasion is that patients sustain a heart attack after or during cardiac surgery. That's less than ideal, but once again can happen. It's a very stressful situation to go through cardiac surgery, right? So there's all sorts of things that could go wrong. There's also sorts of things that could go right. Once again, keep in mind, 90% of intensive care patients actually survive. So, the odds are in your loved one's favor. Now, if a patient shows signs of any of the complications that I just mentioned, right, there's a high chance they will stay intubated and in an induced coma for longer than the actual pathway suggests, right? If the pathway suggests, if hemodynamically stable, if off inotropes, if off vasopressors, if off vasodilators, if there's no bleeding, there's a regular heart rate, there's no temperature, and the patient is off sedation, off, high doses of opiates, they're awake, they're obeying commands, they're weaning off the ventilator, let's take them off the ventilator. Now, that is an ideal scenario. That is actually a very good scenario, right? Now, in your situation, so something must have gone wrong, or there's simply a delay in recovery, there's a delay in stability, right? Sometimes when it comes to severe bleeding after cardiac surgery, patients do need to go back to surgery, right? They need to have the chest reopened. A source of bleeding needs to be found and also needs to be managed, right? And that delays waking up even further because patients are going back to theater or to the operating room. They're put under anesthetics again, and that delays waking up. So I think that this is what's probably happened with your family member, that there are simply complications that nobody had on the radar, right? And 3 or 4 days after cardiac surgery, yes, with a TB, a tricuspid valve repair or replacement, your family member should be out of the coma by now, should actually be out of ICU, but that's not the case, obviously. The other thing that can happen sometimes, doesn't happen very often, but I have certainly seen it, is that patients develop or they go through a stroke, through a neurological event after surgery, right? And then they're not waking up either. You take them off sedation and they're not waking up because they had some form of neurological event, i.e. a stroke, right? That would be terrible. That would be terrible. But that is also a possibility here that something like that might have happened. But the quickest way for us to find out and help you and almost handhold you through this process is by looking at the medical records or by talking to doctors and nurses directly and ask all the questions that you haven't even considered asking, but must be asked when you have a loved one in intensive care, right? So be patient, right? And ask the right questions. I've given you a hint of what questions to ask, right? I've given you a hint of what questions to ask. And it is really important that you know what questions to ask. Okay, now, if you have any questions, type them into the chat pad or join me live on the StreamYard link here. Right, join me live on the StreamYard link here, and you can talk to me directly. If you don't have any questions, I'll go on to the next question that came in during the week. And that question comes from Kaylee. Kaylee says, my 77-year-old, hi Patrick, my 77-year-old husband has myeloma in his hips and he's in ICU on oxygen. They have increased it. We have struggled with being put on a ventilator, and what are his chances of survival or healing if we were to decide to use a ventilator? That is a great question, Kylie. If he has myeloma, I would imagine there is an oncologist involved. What are the treatment options here? What are the treatment options from the myeloma point of view? Have you spoken to the oncologist, right? Also, is this new? Is this old? How long has he had the myeloma for? Well, here's the bottom line. If your husband goes through chemotherapy, radiotherapy, his immune system will be compromised, and he's at high risk of developing a pneumonia, for example. Then getting him off the ventilator will be really challenging. Case in point, I've looked after patients in intensive care that had, for example, myeloma. They've just gone through radiotherapy or chemotherapy prior to their ICU admission. Their immune system was so compromised that they had no white cell counts. They were partly even neutropenic, which means their immune system was basically non-existent. And then it's very difficult to get them off the ventilator. So I can understand why you're asking the question. It's a very relevant question. What are chances to get your husband off the ventilator if you were to decide to put him on the ventilator? Right? So, what should you do? Talk to your oncologist, talk to infectious disease, talk to the ICU team. What do they think his chances are? Ask them, what's his immune system like? You would know whether your husband had chemotherapy or radiotherapy. You would know that, right? And that will give you an indication also. Do you think he's strong enough to pull through? I've seen many patients struggle in situations like that when you put them on the ventilator, but it also sounds to me like he's very close to needing the ventilator. And then it's sort of a case of, do you want to give your husband the chance to get on the ventilator and also wean off the ventilator and give him a chance that way? Or do you not want to, give him a chance in the first place? Right? The question is also, does your husband have an advanced care plan? Right? What are his wishes? What are his wishes? What are his wishes? Right. Okay. So then let's move on to the next question, coming from Princess, who says, hi, Patrick. I was told my dad may not survive ICU, and the ICU team wants to turn the machines off and let him die. What should I do? Well, first off, if you followed my blog for any length of time, you would have heard me saying many warnings that you shouldn't buy into the negativity and the doom and gloom, right? Let me repeat that because I think it's so important. When you have a family member in intensive care that's critically ill, you should not buy into the doom and gloom and the negativity. Now, I might say something now that some people might perceive as controversial. You should always stay positive, always, no matter the odds. It will help you. It will help you. You know. Now, next, if you watch my blog for any length of time, you would have also heard me saying that approximately 90% of ICU patients survive. It's 9 out of 10 surviving. So why would your dad be the 1 out of 10 not surviving? Just because they're saying it? Where's the evidence? Do you have any evidence? If you don't, then you need to get some evidence. So how can you get evidence? You can get evidence by getting a second opinion, by letting us have a look at the medical records. But even more important, let me talk to doctors and nurses directly and let me ask all the questions that you haven't even considered asking, but must be asked when you have a loved one critically ill in intensive care. Next, why are they so negative? Well, they're negative to stay in control of the narrative. What's the narrative? The narrative is designed to be negative so they can stay in control. By them telling you your dad's not going to survive and they just want to switch off the machine, they've already laid out the plan for your dad, right? Is that a plan you agree with? Right? So you are being told something, okay? Would you trust that just because someone's telling you something? Would you verify that? How would you verify it? You know, I mean, these are life or death situations. And because these are life or death situations, you need to verify and you need to have a plan. You need to have a plan because hope is not a strategy. Having a plan is a strategy. So how can you, first off, you now know 90% of intensive care patients survive. So that is the number one knowledge gap that you filled now. So you know that. Okay, so that's good. Next, someone just told you something. Well, ICUs need beds, and they need beds fast because the next patient is already knocking on your dad's ICU bed, wanting the same, needing the same. So one way to manage that is by telling patients and families, well, your family member is going to die, and let's just switch everything off. Next, because they want to stay in control of the narrative, it's also a case of, let's just say your dad is improving and they won't even acknowledge it, right? And then if your dad is deteriorating, it's easy for them to say, I told you so, right from the get-go. Next, imagine they know your dad has a very high chance of improving and surviving, right? And then he doesn't. You could potentially sue them. You could say, oh, you told me he's going to survive, right? So you could potentially sue them. And therefore, you could hold them accountable. You could take them to court potentially. I don't know. I'm not a lawyer. I'm a clinician specialized on patient and family rights in intensive care, right? But you can see where this is going. You always have to read between the lines. You always have to read between the lines. What does it mean? I tell you another thing. So in your email, you said, you're being told that my dad may not survive and the ICU team wanting to turn the machine off. That's a very short statement for a very complex situation, for an extremely complex situation, right? But that's also why I keep saying that the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights. They don't know how to manage doctors and nurses in intensive care, right? It's a bit like saying, I want to go to the moon. Well, there's numerous steps that you need to take to go to the moon. And it's the same here. You want an outcome, which is your dad surviving, but you don't know the steps to take to make that happen. Right? And I know you feel powerless. You probably don't even think that this is possible. Well, let me say this. We have saved countless lives for families in intensive care, or for patients in intensive care with our consulting and advocacy. Countless. Right? And you can verify that on our testimonial section at intensivecarehotline.com, or you can verify it on our intensivecarehotline.com podcast. Right? All of that. All of that. So, you're not even scratching the surface here with your question, and you don't even know what you don't know. If we look at medical records or talk to doctors and nurses directly, I will tell you pretty quickly, well, your dad will or he won't have a chance of survival. Which brings me back to, there's a distinction between a real and a perceived end-of-life situation. Well, what's the difference? I'm glad you asked. A real end-of-life situation is that no amount of treatment, no equipment, no surgery, no medications, no manpower of qualified people will be able to save your dad's life. Your dad is going to die inevitably in the next few days, hours even. That's a real end-of-life situation. A perceived end-of-life situation is that it's a perception that someone is dying. But in the interim, we can do X, Y, and Z to help your dad to survive. And keep in mind that approximately 90% of intensive care patients survive. Keep that in mind. Have that on your radar, first and foremost. They're trying to make you believe that 90% of intensive care patients are dying. It's not the case. And it's not the case. Now, I will say one disclaimer here, though. And you've heard me saying that on other podcasts or live streams too. Just because someone is surviving, I'm not talking about quality of life here. I don't know what the quality of life is going to be like. Nobody knows. But you do know the outcome if you let your loved one die. You absolutely do know the outcome. You don't know the outcome if you let your loved one live and give them a chance. You don't know the outcome there. Right? But if you're not giving it a go, and you let your loved one pass away, as they suggest, you can turn the machine off, sure. Your dad might die, but he might have survived if you hadn't turned the machine off. If your dad had more time. So, and in the beginning of this live stream, I kept talking about intensive care at home. There's always an option for intensive care at home. You know what your dad's life looks like if you throw in the towel. You don't know what your dad's life looks like if you don't throw in the towel. There's plenty of time to talk about end of life. Plenty of time. What's the urgency? Where's the urgency to kill someone in intensive care? Please help me understand. Where's the urgency? Where's the hurry to kill someone in intensive care? I would welcome your comments. Plenty of time to talk about end of life if patients are not improving. In the meantime, we should do our best to save lives. Okay, now, if you have any questions, type them into the chat pad, please, or join me live on the StreamYard link here. Join me live on the StreamYard link here. You can talk to me directly. Now, here's a bit of a random comment, but I actually think it ties right in with the previous email. Rita writes, when we ask them on our website at intensivecareholdline.com, when people opt in for their free email, free ebook and our free email newsletter, we ask them, what's your biggest frustration, right? So we can make better content, so I can understand you as clients better, what makes you tick, so I can, create better content and tailor it more towards you. So here's what this subscriber says. What is the biggest frustration right now? Forgiving myself for not taking care of my husband. It's a broad statement. Could mean a number of things. But running intensivecareholdline.com over the years has shown me the following, that families in intensive care reach out to us often 12 months later, and they say, oh, I've given in to intensive care teams, or the intensive care team stopping life support for my mom, for my dad, for my spouse, whatever, because I didn't know any better. And then they have sleepless nights once their family members have gone, right? And then they start doing research, and then they probably find intensivecareholdline.com and they read that there would have been consulting and advocacy available. And we could have saved their life, their loved one's life, like we have done with many, many other clients. Right? And then it's too late. Then it's too late. And then they want a medical record review. Yeah, we can do that, sure, no problem. But that's not. And then it's too late. You need to act when the iron, you need to strike while the iron is hot. I'll give you a hint there. When you have a loved one in intensive care, you don't know what to do, right? What decisions to make, how to communicate with intensive care teams and so forth. Make decisions today that you do not regret in 12 months' time. Now, in this situation, or in some of the situations we had before, by letting your loved one die, do you think you might regret that in 12 months' time? Keep in mind, when you have a family member in intensive care, you are under a lot of stress, you're running on adrenaline, your emotions are probably flying high, right? And you're prone, and therefore you're prone making the wrong decision. You're therefore prone making the wrong decision. And that's when we get emails like that 12 months later. I need to forgive myself for not taking care of my husband. You don't want to be that spouse. You don't. And I know it's extremely frustrating being in a situation like that when you have a family member in intensive care. It's extremely frustrating. I fully understand that. But you got to work with what you've got. And what's also important is you have to take full responsibility. The families that get the best outcomes are taking full responsibility. They're leaving no stone unturned. They're getting the help they need. They engage us, and we walk them through things step by step. Now, in the last couple of weeks, we have worked with 2 clients, almost kind of identical. No, it's not quite identical, but it started out identical. 2 patients went into ICU after cardiac arrest. They were supposedly having a hypoxic brain injury. ICU gave the families the doom and gloom spiel, saying your loved one is not going to survive. If they do survive, they won't have any quality of life. How many times have you heard that on this channel? How many times have I heard it working in intensive care? Right? So both clients are still alive with the help of us, with the help of our advocacy, because once again, the ICUs were trying to push them into agreeing to end-of-life care, right? Almost trying to force them to agree to end-of-life care. And this is the thing, you need to stop listening to what they're saying, and especially when they try to put pressure on you. They were trying to, get PEG tubes once the ICU realized that the families won't agree to end-of-life care. Then they were trying to push them towards tracheostomies and PEG tubes instead of trying to focus on trying to wean them off the breathing tube and the ventilator in the first place, and potentially avoiding the trach tube and the PICC tube. Now, for one of those clients, a tracheostomy was unavoidable, and that was fine. Bought them some time. But the reality also is you have to question everything. You have to question the clinical judgment from intensive care teams. So what do I mean by that? So if the intensive care team is telling you, well, your loved one is not going to survive, they're surviving today, and then they're surviving tomorrow, and then they're surviving the day after, and the day after, and so forth, you have to question their clinical judgment. You have to question their clinical judgment. Is their clinical judgment driven by politics or by a hidden agenda to empty ICU beds? Have you considered that? Is it politics? You have to consider all of those questions. Now, here's another question that comes in from Kaylee, who says, "Hi Patrick, my husband has been on a ventilator for 14 days now, and they want to do a bronchoscopy. Would that be the right thing to do?" My answer to that is, once again, that the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. That is the challenge here. Because, without looking at the medical records, without having more context, I simply wouldn't know. Is your husband having a breathing tube in the mouth, or is your husband having a tracheostomy? Does he have secretions on his chest? Are there that many secretions on his chest that they need to do a bronchoscopy and suction it out while they're in there? So a bronchoscopy, for anyone who wonders what's a bronchoscopy, it's basically sticking down a video camera into the lungs to have a look what's going on in there. But that also is an option to then do some deep suctioning, right? What else is going on? Why did your husband go into ICU in the first place? Can you see that without, a situation in intensive care so complex that you are giving me 0.5% of what I need to know to give you an answer? We are talking about a very deep topic here. As much as I would like to simplify for you, and I try to simplify as much as possible, it took me decades to talk about the topic confidently here today. Took me decades of studying, work experience, looking at medical records, talking to clients, talking to doctors, talking to nurses, doing the hands-on work, right? I have all the answers for you, but I need more information. I need more context. Right? But most likely he's got some secretions there that they either want to suction, or, God forbid, they're suspecting maybe something malicious going on in there. Do they want a biopsy, to check for cancer, or, I don't know. But you can see where I'm going with this. Here is another email from Jessie, who says, "Hi Patrick, I just need to know, what do you suggest I do next? My sister is in ICU and keeps having brain seizures." I'm sorry to hear that, Jessie. Once again, you're giving me 0.5% of the information I need to know to confidently answer to you, what should you do next? Because I don't know where are the seizures coming from. Why does she keep having them? Did she have a cardiac arrest with a hypoxic or anoxic brain injury? Is it something else? Does she have encephalitis? Do they come out of the blue and they don't even know why it's happening? Right? The first question that I would have for them is, why do they think it's happening? Have they got an explanation? And what are they doing to manage it? What medications is she on? How are they managing the seizures? Right? Is that potentially preventing her from waking up if she's in an induced coma? Right? I wouldn't know without looking at the medical records or without talking to doctors and nurses directly and finding out what is exactly going on. Once again, you're giving me 0.5% of what I need to know. Do you have access to the medical records? Right? I wish I could simplify the topic anymore, but once we have access to the medical records, you will see it's flowing. Or if we talk to doctors and nurses directly, once you and I get on a call to doctors and nurses directly, you will see how things will open up for you. Right? You will see that things will open up for you pretty quickly. There's a whole new world besides it, beyond it, and you will see that it's all about having the right solutions. And I mean, the question is, how can you, if you have a loved one in intensive care where it's life or death, how can you not get a second opinion? Right? How can you not get a second opinion? Doesn't make any sense that you're dabbling around here. Right? Good morning, Dale. Dale, do you have any questions? Just type them into the chat pad if you do. If you want to talk to me directly here, do that. In the meantime, if you have any other questions, type them into the chat pad or join me live on the StreamYard link here. We do have a few more minutes. Okay, so now next question. Another interesting comment from Pia, who says, I don't know the whole truth of what's really going on. Yeah, no, of course not. Of course not. How could you? Unless you're getting a second opinion. How could you? You don't know what you don't know. And you will see, once we start breaking things down for you, you will see how a whole new world will open up for you. Whole new world will open up for you. Where you can turn things around pretty quickly. You're going from, oh, the ICU team said, oh, my family member's not going to survive, to, oh, they are actually surviving. Let's see what's possible now. Let's see how we can get them back on track. Just like we've done with those other two clients in the last couple of weeks, who are now on their path to recovery. One of those patients is being decannulated, having the tracheostomy tube removed in the next few days. ICU said she's not going to survive for the next 2 days. She's on her way home now. Right? Anything is possible. Anything is possible. Most end-of-life situations in intensive care that you're being told of are actually perceived end-of-life situations and not real end-of-life situations. Right? So, once again, thank you so much for joining today. If you like what I'm doing here, subscribe to my YouTube channel, give the video a like, share the video with your friends and families. The algorithm also likes when people comment, ask questions so that more people can find us here. Creating a community of like-minded people. Creating a community of people that want to improve their family members' lives, right, or their own lives. Sure, that's good, Dale. Just thought I'd pop in and say hi and see what your life was all about. I have other topics I'll contact you directly about in regards to collaborating with the company. Yeah, sure. Thanks, Dale. Thank you. These live streams here are about answering questions for families in intensive care or for families in intensive care at home. That's what these live streams are for, right? Certainly interested in a different perspective on end-of-life situations, yeah? It's all about perspective. It's all about perspective, Yeah, that's great. That's great. All right, so, yeah, give the video a like, thumbs up, share the video, subscribe to my YouTube channel, and comment below. And also, visit our website, intensivecarehotline.com or intensivecareathome.com. We have a membership for families of critically ill patients in intensive care, and you can become a member if you go to intensivecarehotline.com. If you click on the membership link, or if you go to intensivecaresupport.org directly in the membership, you have access to me and my team 24 hours a day in a membership area and via email, and we answer all questions intensive care related. In the membership, you also have exclusive access to 21 ebooks and 21 videos that I have personally written and recorded. And the access to me and my team and the access to ebooks and videos will help you to make informed decisions, have peace of mind, control, power, and influence, making sure your loved one gets best care and treatment. I also do one-on-one consulting and advocacy over the phone, Zoom, Skype, WhatsApp, whichever medium works best for you. I talk to doctors and nurses directly. I talk to you and your families directly, and I handhold you through this once-in-a-lifetime situation that you simply can't afford to get wrong. I also represent you in family meetings with intensive care teams. We also do medical record reviews in real time so that you can get a second opinion in real time. We also do medical record reviews after intensive care if you have unanswered questions, if you need closure, or if you are suspecting medical negligence. But it is so much better if you have the medical record review in real time. With intensive care at home, we are currently operating all around Australia and all major capital cities, as well as in all regional and rural areas. We are NDIS approved, TAC and WorkSafe in Victoria, DVA all around the country, DVA and NDIS all around the country, ICARE in New South Wales, NIISQ in Queensland. If you're in the US or in the UK and you need intensive care at home, reach out to us. We can help you there privately as well. And remember, we're doing NDIS support coordination as well, level 2 and level 3. And we're looking after ventilated clients at home. We're providing a genuine alternative to a long-term stay in intensive care. We're also providing tracheostomy care, BiPAP, CPAP, home TP, and home IV potassium infusion, etc., etc. Thanks again for all your support. Thanks again for watching. And I will see you again during the week in my quick tip videos, and I will see you again next week, same time. Take care for now.